So after the tone muscle power, next will be the reflex. So there's few places to do the reflex in upper limb. So we have pre-reflexes to do, which is a bicep reflex, checking the nerve power of C5 and C6, supinator reflex, and tricep reflex. So there's three places to knock in one side of the hand. So you need to remember to do this reflex, the patient has to relax. They cannot contract or stiffen their arms. If they do so, you won't be able to get the proper reflex. Okay. And then if let's say the reflex is negative, you cannot see the reflex, you need to do a reinforced maneuver by asking them to clench their teeth together while you tapping the tendon. This reinforced maneuver mainly is to distract the patient so that they don't consciously tense up their muscles for us to see the reflexes. Let's see how you do. So ask them to relax, and then by first thing you check will by bending the elbow, relax and bring the elbow to the abdomen, so patient's arm the muscle can relax, and then you put a hand at the feeling the bicep tendon, and look at how he hold the tendon hammer. So I want you to focus how he hold the tendon hammer here. So your hand always hold at the very end of the tendon hammer so that it swing itself. So you want a very good swing, and then the hammer will just move along with the inertia. So have a good swing, and you want the rubber part of the hammer hit on hit on your fingers in the index finger. Okay, so see how you hold at the end, and they just very lightly swing the tender hammer and let it land on your finger. So where does you see? So reflexes for bicep, you want to look for bicep contraction. So this part of the muscle is called bicep. You want to see whether the muscle does contract or not when you hit when you hit the tender hammer on the bicep tendon. Normal response, the bicep will contract, and your index finger on the left hand will also feel a movement, because when the muscle contract, the tendon will move as well. Okay, that's for bicep reflex. So you always compare both sides, side to side. Okay. After that, you move on to supinator reflex. So you ask the patient to position the hand like that in the midline, slightly pronate, so that the thumb is facing upwards, and then you put your hand on the supinator muscles. So roughly the muscles tendon run along the bone. So you put your hand roughly. Usually you just put your hand just below this radial pulse here. So you feel your radial pulse here. Just put your finger just distal to it, and the same thing you hit on your finger, and you feel for muscle movement, and you look for supinator muscle contraction. So the supinator muscles is this group of muscle. You want to look for any contraction here. Okay. So you compare left and right side, and the last reflex you want to check is the tricep reflex. So where do we hit on the tricep reflex? So these are bicep muscles. Can you guys see my arrow actually when I move my cursor?
Can.
Yeah. So this group of muscle is called bicep. This group of muscle at the back is called tricep. So tricep actually in a way at the behind of your elbow bone here. So it's called olecranon. So the tendon actually, if you feel your hand at the end of the elbow here, you feel one bone, right? This is called olecranon. Just above it, you actually can feel a tendon. You can feel a tendon. So that's where we land our tendon hammer here. So yeah, you try to hold the hand so that remove the gravity so that the hand can relax, and then you swing the tendon hammer, and for tricep you don't need to put your index finger there. You just swing directly at your tricep tendon. Okay, so see here. All right. So when you swing just now, look where it landed. You want it to land at the tricep tendon, and your vision actually focus on the tricep muscles, whether it's contract or not. So if they contract, usually you can feel some movement, extension of the elbow as well. Okay, so that is reflex. Okay. So the next is okay. So for reflexes, upper motor neuron, I mentioned just now hyperreflexia. If you have low motor neuron, it's gonna be hyporeflexia. Okay. So the next thing is sensation. So there's 4 sensations that we can perceive and we can examine as well. It's pinprick sensation, fine touch sensation, proprioception, and vibration. The proprioception means that the sensation of your joint position. So, but then we don't actually routinely check for all 4. Like I mentioned just now, our sensation travel through 2 different pathway along the spinal cord, which is your the spinal thalamic and also your dorsal column. So dorsal column responsible for proprioception and vibration signals, while the spinal thalamic responsible for pinprick and the fine touch. Okay. All right. So another term I want you to introduce is called dermatome. So dermatomes is just that tells you that it's just a definition, means that this certain part of the skin here is responsible by a certain peripheral nerves. So each part of this sensation at this certain part of the body is responsible by different nerve roots. So this is what we're talking about. This is what it means by this this diagram with the numbers. So each part of this demarcated line responsible by these numbers, and this number is actually the number of the nerve roots exits from our spinal cord. So for example, this area is C4 dermatome. So this area is signals is received by spinal cord nerve root at C4 level. So that's what we mean by dermatome. And the way we examine, we also follow the dermatome as well. So we will check the sharp sensation and upper limb. We're following the dermatome area. So if let's say, for example, C6, when you loss of sensation in C6, then we will know that, oh, C6 is the nerve growth that we are talking about that may damage. The lesion likely is at the cervical, roughly is at the cervical region. So this is a cross section of our spinal cord. So from brain comes up to spinal cord, and the spinal cord exits. All these are what we call nerve roots. So you look at this image here. Our spinal cord is like a rod-shaped pipe like that, and then you comes out with nerve roots. So one left and one right, responsible to sensation in each side of the body. So for example, nerve root number 4, if let's say you check something, maybe here, nerve root number 6. So if someone comes in with reduced sensation at this part of the body, then you think that, oh, maybe there's something wrong with the cervical cord, then you image this area. That's how we localize this. Okay, let's say someone has reduced sensation at the middle finger, then we know that, oh, likely lesion is in the C7. So we focus at C7 here. Okay. That's what we talk about. That's what we mean by dermatome. It's an area of the skin that responsible by a certain level of nerve root innervation. Okay. So when we do, how do we remember that? So usually you just follow logic. The way innervates you notice that because the cord is like that, so the numbering actually following from upper to from cranial to caudal, means that you follow a number from upper part innervated by higher nerve roots. So at the clavicle area there's C4, at the arm, at the shoulder area is C5, at the forearm is C6, while C7 is the middle finger, and C7 is the middle finger, C8 is at the little finger, and then T1 is the inner part of the forearm, and T2 is higher up at the armpit area. So usually that's how we remember. Just remember following C4 at the clavicle, C5 is the outer shoulder, C6 is the outer forearm, C7 is the middle finger, C8 is the little finger, and then T1 will be your inner forearm, T2 is the inner armpit. So it's following the number. Just remember C1 to T1. So that's what we are checking here. So you follow the sequence going down and up, then it's easier for you to remember where to check. Okay. So let's see how you do in the video. So you start off by checking the T2. Now he's checking the C4. Now he's checking the C5 by the checking at the outer forearm. Outer arm. Then you check at the C6. Checking at the C7. So when you do that, the sensation testing, you always ask, does the sensation, you ask the patient to close their eyes, and then you touch them with whatever sensation you want to touch, like sharp, you use a pinprick. If you touch, you use a cotton wool. So you ask them to close their eyes, and then you touch their certain area on the body, and you ask them whether can they feel it or not. This is question number 1. So if let's say they can feel it, then you compare both sides, and then you ask them again whether it feels the same or not. So he's checking the C8 at the little finger there. Then he's checking T1 at the inner elbow area. And he'll repeat after the sense of touch. You repeat with the pinprick for the pain. Yeah, so he's repeating the same process from C4, then doing it on C5, then moving down to C6, then to C7. So you just see how you move from outer to inner, then you just follow that sequence, then it's easier for you to remember. Just from outer to inner. Okay, follow the number, then to T1. That is for sharp. I check for vibration. So for vibration, we use the tuning fork. So how do we check it? So by showing them how do they feel first on the sternum. They vibrate this tuning fork, and then if they can feel it, and then you will stop the vibration for tuning fork, and then you ask them to tell you when they feel that the vibration has stopped. Okay, so you test it on the bony prominent. Okay. So they put they vibrate the tuning fork before they touch the patient, and then they put this pointing area, this contact area at the patient's bony prominent. Okay, if they can feel it, so and then they will stop the vibration. The patient has to tell him when does the vibration stop. Yeah, so he will stop the vibration, and then patient, if they can feel the vibration stop, they'll tell. If let's say you can't, then you have to move on the bony prominent. If you cannot feel, you have to move on to the wrist area. If you still cannot, you have to move on to the elbow bony prominent area, and etc. You move upwards towards the body. So start with the hand. If you cannot feel, they go on to the radial prominent bone here. If you still cannot feel, you move on to the elbow bone. Okay, then the next sensation is called proprioception. It's a sense of joint position. So with the eyes open, you show the patient first how does it feel like. So you move the thumb, tell them this is going up, this is going down, and this is the neutral position. And then you ask them to close their eyes, and you move the finger this time, and you want them to tell you this is up, this is down, or this is neutral. Okay, so focus on how they hold the finger. So you want to hold the thumb at the side and not top down, like a bit like that. Because when you put if you hold the thumb at top down position instead of left and right like this, the thumb can feel can feel your finger. So that will affect the sense of proprioception. So you want to hold the thumb or hold the finger like that at the side, and then by moving it, ask the patient close their eyes and tell them where is it? Where is the thumb? So up. Okay. So by moving the joint position, ask the patient uh, see whether they can tell where is the joint now or not, whether it's up, down, or neutral. So all these are assessed with the patient's eyes closed. So that is for sensation. So the next thing will be your coordination, which is called cerebellar sign. So this coordination movement is in charge by a cerebellum. So by doing this is to check whether your cerebellum system is intact or not. So there's two tests to check for cerebellar. The first one is called finger to nose test, where you ask the patients to do something like this. Use the index finger to touch their nose, and then to touch your finger, and then so you ask them to touch the finger. So you look at the hand. So the proper distance between patient and your finger is gonna be a one hand stretch distance. Their elbow has to be fully extended. It cannot be bent. Okay, and then once you touch the finger, you try to move along this line. So you move left and right and ask them to follow your finger. So there's another name for this called pass pointing, where when or finger nose test. So the positive findings means when that finger cannot touch your finger easily. When they start to have tremors, when a finger misses your finger, that's called pass pointing. So this is normal. You can easily touch the fingertip, and you change to the other side. Okay, that's pass pointing. The second one is what we call dyslexical kinesia. So you want the patient. Dyslexical kinesia is a term for inability to perform a rapid alternating movement. So what do we mean by that? You ask them to lift up their hand and then turn over the palm. Okay, the patient must lift up their palm in order to do this movement. They cannot do like flipping the book like that on the palm. That's wrong. So look how is the movement again here. So you have to lift up and turn over. This is the correct movement. So the patient have to do as fast as possible on one hand and then turn to another hand to assess the different side. Okay, see they have to properly lift up the whole palm from the other hand. Okay, if after you've done that, that will be the end of your neurological exam. Okay, any question? Any question?
No, that's it.
Is it too complicated?
I think it's very straightforward, doctor.
Okay,
From
I
based
hope
on
you
the
do well.
slides lah, based on the slides. I
Okay.
mean, the dermatom is another different thing to memorize, but then everything
We do
should
it few
be.
times, you guys will able to remember it. Okay, so there's one thing last week I forgot to talk to you guys about, but I think after you guys know what is upper motor neuron and lower motor neuron, then now is a good time to talk about. So what do you see on this picture here? This one, okay, here. All right. So what is the difference do you see? Maybe we talk about the left side here first. So you ask the patient to smile, then you see there is some. Do you see symmetrical or asymmetrical first?
The same.
Yeah, there's a facial asymmetry, right? When you ask the patient to smile, one side of the mouth is not lifted up. You see the eyes can open quite big here, but the look at the forehead here is also affected as well, isn't it? So what is this called?
Bell's palsy.
Yeah, I mean the answer is behind it, below here. Okay, so this is facial nerve palsy. So what about this one? And then this picture is more subtle, but it's very difficult to find this photo. So look at this. Do you see facial asymmetry or not? I know it's a bit subtle, but you look carefully at the nasolabial fold. Is it deep enough compared to this one? In terms of the depth of a nasolabial fold.
The left side is deeper lah.
Yeah, this side is deeper, this side is less, right? So sometimes it's subtle, but then you can compare with the previous photos. Sometimes it can give you some clue. But if let's say, just pretend that, just acknowledge that this is asymmetry. There's some facial weakness here, but look at the forehead. How about the forehead? Can he lift up the forehead muscles or not? Look at this. And this one. This one you can see very clear. This is a palsy on the forehead as well, right? Look at this one. Does it involve the forehead or not?
Yes, I mean, he can lift his forehead.
Yeah, means it's not involved, right? So this is also a facial nerve palsy, but then there's a difference between the two. Okay, so when there's sparing of the forehead wrinkling or forehead muscles here, so this is what we call upper motor neuron lesion. Okay, this is an upper motor neuron facial nerve palsy. When there is a involvement whole side of the face, including the forehead, that is lower motor neuron lesion. Okay, this is a concept I want you guys to remember. So why does it happen like that? It's just a simpler concept. You just remember that um, your forehead area is innervated by both upper and motor neuron pathway from the brain. If let's say while only the forehead is innervated by the upper and lower motor neuron, and your rest of the face, the rest of the facial nerve, like your nasolabial fold here, is only innervated by lower motor neuron. Okay, so when you have lower motor neuron, when you have total palsy, means that you have one-sided fully palsy, that is called lower motor neuron. When you have sparing of forehead, there is upper motor neuron lesion. Just remember that concept. Okay. Okay, so remember again, this one is a summary of the difference between upper and lower motor neuron of the facial nerve. If you have entire face affected, that is called lower motor neuron, and you have spared forehead, that is called upper motor neuron. So the pathology and location of lesion will be different, and like the brain and brainstem that we talked about just now. If you see upper motor neuron lesion of the facial nerve, the likely lesion is in the brain or brainstem, like stroke, which is commonly seen. Well, facial nerve palsy, the lower motor neuron facial nerve palsy give you one-sided whole ipsilateral face palsy, and likely lesion will be like herpes zoster, Ramsay-Hunt syndrome, or Bell's palsy. Okay, remember this, uncle. Okay, remember the face. This one again. Repeat again. Sparing upper forehead, and also involvement the whole face involving the upper forehead. That is lower motor neuron facial nerve palsy. Sparing of forehead, upper motor neuron facial nerve palsy. Okay, common causes of upper motor neuron lesion, stroke. Common lower motor neuron facial nerve palsy, Bell's palsy, herpes zoster, Ramsay-Hunt. Okay, straightforward, right? Okay, that's the end. Any question?
Doctor, I have a question. Doctor, do you have any tips for us for ESOT?
I give a lot of tips already. I think go back. The type of questions is very similar than with your mini test and this time around. Okay, so go back to the pictures that we keep on repeating to you. Okay, I think we don't have that many lectures since the beginning. Also, I think less than 10 lectures. So you focus on the important lectures. Dumb questions I did not put up that much. So we focus on non-dumb lectures. Okay, that will save you half of the time. So focus on the photos. Focus on the photos, the ECGs or X-ray that we have been keep on talking about. Okay. So we go through a lot of images before, right? So especially the X-ray one, go through it again and again. There are multiple X-rays that we keep on presenting. So those will be the important one, huh? Then okay, this one. Okay, you guys see this? Can right? You guys see this slide?
Yes, Doctor.
Don't worry. This ECG will haunt you for life, one. Okay, right. Come. So the ECG will come out again and again. I want you to remember the concept that I'm talking about just during the last lecture. Somehow I think during when I marked your last exam also, there's still people confused about the ECG. I'm not sure which part that you guys don't understand. So I'll go through a few pictures and let me know if you still cannot understand. Okay. So how do we count the rate? So we measure the big boxes and then we divide by 300. Easy, right? Okay. So what do we mean by the big boxes here? So okay. So this is what we mean by the big boxes. So this is one big boxes. Let's say we count from here, roughly around here. So roughly here from here will be one boxes. Here to here will be two. Here to here will be another. So 3. That is 4. Okay. So 300 divided by 4 will be how much? So it's 100 here.
75.
75.
Anyone confused or not? Because I'm still getting confusing answer in the exam. Let's try another one. Okay, how about this one? This one. So, roughly here you get how many boxes? Just very roughly, maybe you take this one. So this is one boxes. This is another boxes. So how do we count the boxes? So we count it between the peak to peak. We call it bit to bit. So how do we know which bit? So we just take randomly which bit that landed at the point here. So you can take any point that you want. If let's say the heart rate is regular. So you take this one to this one, peak to peak, you get one box, two box. So what is the heart rate?
150.
Yeah, anyone confused or not? Is anyone confused?
Doctor, I noticed during the exam, right? You give us the ECG, right? All the waves things. Can't there's like different types of leads?
Any lead will
I
do.
mean,
It doesn't
I'm
matter.
not saying different types.
Doesn't
It's
matter. Whichever lead is also okay one. The rate is gonna be the same. So we just pick wherever lead that is show nicely that you can see the QRS very nicely. Because sometimes the lead is It's like that, like that, like that. Not nice, right? You see the lead that you can easily pinpoint where is the peak, where is the QRS. Oh, right now. You find a very good peak that landed just at the line. Then it's easier for you to calculate lah. Here to here is 2 box. Okay? Easy concept, right? Anyone confused or not? Okay, any question? Any question until here? Okay, so this big square is equivalent to 0.2 seconds. Okay, this one to this one is equivalent to 0.2 seconds. Okay. Okay, that is for heart rate. Okay, then this one, this one, this one. So the rhythm also is a very simple recognition that very important that you guys remember. What is sinus rhythm? What is sinus rhythm again?
Which we can see QRS.
Now when we can see P, Q, R, S. How about in sinus rhythm, usually how is the heart rate? How is the rhythm? It's regular, okay? If you look at normal rhythm, the Q and Q interval usually will be very similar, very regular. Okay, we look at this, three boxes, all will be very regular. Okay, then you have something is irregular, something like that. When they're irregular, you can't see P wave. What is it called? Atrial fibrillation. Okay, I want you to remember the pattern. Okay, it's a very simple slide. You just have to remember the pattern and what do we mean by atrial fibrillation, what do we mean by sinus tachycardia. Okay, this pattern. That's okay. And remember the pattern, huh? The how it will. This heart block is okay. You want to let it go, I think it's fine. So remember the pattern. So what do we mean by VT? Ventricular tachycardia is very bizarre QRS pattern, regular, bizarre. This is called VT. Okay, when it's bizarre, you cannot see pattern. It's like bags of worms like that. It's called VF, ventricular fibrillation. Okay, you remember the pattern. You don't remember the definition like that. Okay, again, straight line means patient is dying. Your patient is dead. A bag of worm is almost dying, so it's called ventricular fibrillation. Remember the pattern. A bag of worm, very scribble like that, very messy like it's VF. A very regular pattern, bizarre looking, very broad QRS complexes. You can't even pinpoint where it's a P wave. This is called VT, ventricular tachycardia. All right. I do not expect you to differentiate monomorphic or polymorphic. Bizarre looking, broad QRS, it's called VT. Monomorphic means it's just a mono, means it's everything looks the same. Polymorphic, it doesn't look the same. They are big, they are small. It's called polymorphic. Right? Understand? Remember the pattern. Okay? Next thing, what is myocardial infarction? Remember definition of myocardial infarction? What do we mean by STEMI? So I don't know whether you guys can remember what do I teach or not for the ST segment. So this is normal ST. You see, it's flat. You can draw a straight line across. Okay, this is normal ST. So what is ST elevation? So PQRS. This is ST. So is it elevated or not?
Yes.
Yes.
Prominent, right? Okay. This one is elevated or not?
Yeah.
No line.
The one.
Elevated, okay. You can draw one straight line. This is not elevated. Okay. This one is elevated or not? This one is elevated or not? Yes or no?
Yes.
Yeah, yes. Okay. Okay, let's see the photo again. Okay, let's see the ECG again. So there's so many leads, which one to see? The answer is you look at it every single lead. Okay, you look at 1, 2, 3, look at LVR, LVL, LVF, you look at every single one of them. Okay, not looking at which one, looking at all of them. Okay, if you want to count the rate, you can pick any one, but you want to look at ST segment, you look at every single one of them. Okay, let's do it now. Okay, let me zoom in. You can zoom. Okay, so this one. How about the ST segment? Is it up or down or normal? Just tell me up, down, or normal. Come, the faster we finish this one, the faster you can go back. This one normal, up or down?
Up.
Okay. Okay, maybe this image is a bit small. Okay, maybe you have to go closer. If you draw one straight line here, okay, it's actually similar, isn't it? Okay, so you want remember which part is P, which one is QRS, which is T. Okay, so again, this is P, then followed by a QRS pattern. This QRS, and then that coming up next, this is the ST. Okay, this is the ST segment. Then the T. All right, the flattened area, this is called ST. Okay, come again. So now the ST, is it up, is it down, or is it normal? We talk about this one, lead 2 here.
Normal.
Yeah, normal, very good. How about lead 3 here?
Down.
Yeah, very good. Okay. How about this one? Okay, again, P is here. Okay, QRS is here, and then in between here is your ST. Then this is your T. So this is normal, this is up, or this is down?
This up.
Yeah, okay, this pattern is up. Okay, you see this one, the whole thing get dragged upwards. So where do you see the ST up now? So if you see this one, okay, I recognize this pattern. So you want to see every lead here. So V1, V2, V3, V4, V5, V6, which one is up? You tell me. Is this up or not?
Up.
Okay.
Up.
Yeah, this is up, right? It's very prominent. This is up. This one is?
Up.
Yeah, this one?
Up.
Yeah, up, right? So very prominent, right? So all these are up. So where is the ST up now? You want to summarize. So there's a ST up at, so there's ST up at V1, V2, V3, V4, and V5. Correct. Understand?
Yes.
Yeah. Clear, right? Okay. So okay, let's do it again. So how about this one? So you go every single leads, okay? Is this up, is it down, or is it normal?
Down.
Yeah, okay, very prominent, very good. So this is down. You can see, right, this segment. So you compare with the isoelectric line that we draw like that. This is the isoelectric line. You see the baseline is like that one. Then your ST segment is here. So it's lower than the baseline is down. So where else do you see down? So let's try V1 to V6. This is? This one is more or less the same. So you started, the ST actually is here. So this is normal. This is?
Up.
No. You can draw a straight line. When you can draw a straight line, it's not up. When you can draw a straight line across like that, this is normal. If you draw across, if you draw one straight line across, if you below your straight line, this is?
Down.
Down, yeah. More prominent, of course, is V4 to V6 line. So you draw one straight line here. Anything below it is down. It's down. Okay, everyone clear now?
Yes.
Okay, if not clear, better voice out now. Okay. Yeah. So just go through this again and again and again. Okay. Okay. Done. Any question? If no, then we can take attendance.
So, Doctor, last question.
Can come.
For this chapter, the CNS history taking for upper limb, is it usually asked in MCQ or SAQ or OSCE?
It can be asked in anything, or you can ask in the SAQ. MCQ a bit difficult. MCQ a bit difficult to ask.
Okay. Will this also will go in ISOT, right? Is it?
I asked until this lecture. Do I include? Yeah, I think I include until this lecture.
Oh, okay. Thank you, Doctor.
Focus more on the. What do I put in exam? Let me think. Yeah, focus more on the previous lecture. Okay, so I think whatever important, I keep on repeating again. So you will remember it. Okay, so focus on more on the lectures that recently that keep on talking and repeat and again. Okay, and don't empty the exam question. Some of them I realize, I think got a few of you guys empty, you pass out empty columns inside. So I cannot give you marks. There's no negative marking. So whatever wrong answer also, I would minus your mark. So you cannot think of something, you just spend your time write something there. Okay. I'll try to give marks if let's say it's reasonable. Most of the questions are relevant and we talk about it already. So if you don't know what it is, you try and see, use some logic, common sense to answer. So if you think it's logic, that will give some marks. But don't empty it. Okay, don't empty the questions. Don't empty the answers. Okay. So if you look at the common question during the mini test also is they give you a scenario, ask you to ask some questions, that's a history, right? So those are the answer is you can crap a lot of things, but you write something is relevant, don't write too far away. So most of you can easily score some points on those kind of questions pattern. So some of you is we didn't restrict your answer, you can just write whatever you like. Yeah, I think logical. Then I will give some points. Okay. But then you cannot give me contradict answer lah. Like let's say I give you, is this SD up or SD down? You cannot answer one SD down, then the other answer SD down lah. Then I don't know how to give you marks. Okay. So, yeah. Anything else? If not, we take attendance.
We take attendance, Doctor.
Okay.
Shana. Ina? Oh, Ina is here. Okay. Wait. Okay. 1, 2, 3. Thank you. Thank you, Doctor. Happy Valentine's Day.
Thank you, Doctor.
Okay. Oh, the
Thank you,
one
Doctor.
Mark wanted to do the lecture earlier. Okay, where you want to go, Mark?
He has a point later, Doctor.
Okay, bye-bye.